everybody, and welcome to the GEF. We have tonight our guest, Professor Ehab from Cairo. Is the head of department at the Institute of Ophthalmology, and he will talk about pediatric vitreoretinal disease. Ehab, you can share the screen if you want, and you can start whenever you feel comfortable.
Okay. Well, thank you, Adel. Thank you, Dr. Marco, for the kind invitation. It's always a pleasure to be with you. And I definitely like to be always with you guys in King Khalid Eye Specialty Hospital and exchanging thoughts and ideas. Well, my talk today is about pediatric retinal detachment. Why do I consider it different than doing adult vitreoretinal detachment? There are several things that we'll discuss during this presentation that makes me say that this is different, and it's a different type of detachment that has its own considerations. These are my financial disclosures. There are 4 points that I would like to highlight. The size of the eye and the sclerotomy site. Depending on the size of the presentation, you have to configure where you're going to put your sclerotomy site. A 1-month-old baby is different than seeing a 12-month-old boy, and it's different. The vitreoretinal adhesions and the hyaloidal attachments is different in a pediatric eye than in an adult. The lens size, if you compare the size of the lens to the size of the eye, depending on the age of the presentation, you have to keep that in mind in decision making. Should I remove the lens to get to the retinal periphery? What I'm going to do with amblyopia thereafter? Single eye or both eyes have a problem. The last point is the PVR. It's different in pediatric age group compared to adults. So these 4 points are very important to keep in mind. Let's speak about the first point, the size of the eye and the sclerotomy site. For a full-term baby, he only has 1.8 millimeter of parus plana. So that means you can't do your sclerotomy sites at the regular sites. If you see a presentation for the child with the retinal detachment that is 3 months of age, you know that he only has like 1.8 millimeter of parus plana. So that guides you where you're going to put your trocars. It's different. You can't have enough space more than 1 millimeter behind the limbus. It doesn't reach 3 millimeters before 6 months of age. So if it's already 3 millimeters, then that means I'm going to put my sclerotomy at 2 millimeter behind the limbus. So again, if we just summarize this, how am I going to put my trocars? Then I have to know how far from the limbus. If it's within the first 3 months, usually 1 millimeter behind the limbus is enough. If you go beyond that, you're not safe. And make sure that the sclerotomies are parallel, that you can't go as we do it to the visual axis or you'll be hitting the lens. So you try to customize it while pushing the trocar inside the eye, avoiding the lens because the lens is large, and avoiding damaging the retinal periphery at the same time. So you have to know where you're going to put your sclerotomies. What type of instruments could we use? We all know about their small gauge. Should we use 23, 25? Is there a difference? It depends upon the anatomy of the pathology of the membranes you're dealing with. If they're tough membranes, then you can't use small scissors. The vitreous removal separation, you have to have good fluidic to separate the hyoid. It's difficult in pediatric age group. Access to the retinal periphery, the instrument stiffness. If the instruments won't stiffen up, then you won't reach the retinal periphery. And the wound healing. It's very important to tightly close, not depending on a small gauge, but even if I use a small gauge and if there is leakage, I definitely have to close these wounds, especially in pediatrics, and I don't take the risk. And at the end, what is efficient and safe in your hands is the gauge to deal with. Most of the time, I usually do it 25 gauge. It gives me better access, like in this child that had retinal dragging at the ciliary processes. I can use a 25 gauge scissor or a vertical scissor or a straight scissor to cut between the retina and the ciliary processes. A 23 will be a little bit larger, though it has better cutting blades, but you could do it 25, not 27. The same thing, 25, you can do it bimanually. You have a good grip with the forceps and a good blade to cut with if you decide doing bimanual surgery in cases like this. So usually, most of the time, I prefer 25 gauge or 23 in some patients. What did the industry help us in infant surgery or pediatric retinal detachment? Alcon has a special pediatric cannula, which is 3.2 millimeter. It's different between the regular 4 or the 6, so it's in between. It's smaller like this, but it's a sew-on cannula. You can use it in pediatric age group. DORC also have their own pediatric set with a small infusion cannula. The consideration is the size of the eye. I'm trying to avoid damaging the lens while putting my cannula inside the eye, avoiding the retinal periphery if I have anterior retinal pathology, and at the same time avoiding subretinal placement. So this equation tells you how you put the trocar inside the eye and which trocar cannula you use. Like in this patient, I'm doing this case, it was an ROP case. He has anterior retinal dragging, but the lens is touched by the retina right here. But there is some clear areas. So before I attempt putting my cannula, I'd like to indent all around first. I'm deciding that to go 1.5 or 2 millimeter behind the limbus, but in which quadrant do you put your infusion? It's very important if you're planning doing lens sparing vitrectomy. So I'd like to indent like this. Then when I find the correct quadrant, I can put my instrument here. I push the trocar cannula midway and examine before pushing or sliding. I'm in the right plane, then I slide the cannula all the way, putting it behind the lens anterior to the dragging of the retina to avoid damaging both of them. Then you can put your instrument, start to separate the adhesions or the touch between the retinal fibrovascular tissue and the back part of the eye, and keeping this surgery lens sparing vitrectomy. Now, what about other things? The probes also for pediatric surgery, there is a special set for pediatrics by Alcon. It's shorter, it's 18 millimeter. If you compare both probes, this is an 18 millimeter pediatric set, and the light pipe compared to the adult light pipe. DORC also have their own set. If you compare both probes, this is 21 millimeter pediatric vitrectomy set by DORC compared to the 18 millimeter by Alcon. So shorter probes definitely are better in pediatric surgery, especially if you're dealing with in the first 5 years of age and there's a small eye, then shorter instruments will help you instead of damaging tissues inside the eye. Not just the gauge or the shortness, but also the configuration of the tip. The closer you come to the tip, the better you can do delamination inside the eye. And this is also nicely shown with the new Alcon probes, which usually have a beveled tip, so you can come close to the membranes, 0.09 compared to 0.18, which gives you better access to shave or remove membranes off the retinal surface directly. The last point in the vitrectomy sets, which I speak about regarding the probes, is the duty cycle. Controlling the duty cycle with a beveled probe like this, you can definitely do a lot of job inside the eye instead of exchanging instruments, especially when you don't want to have big blades of instruments like big scissors inside the eye that might damage the retina if you're close to the lens and things like that. So you can see that with the probe, you can do a lot of things. When you indent, this avoids having bimanual surgery because you can support the retina inside the eye. And I can use the cutter to delaminate or open planes or remove tissues off the retina here while indenting from the outside by direct visualization. And you can see the thick membranes are easily delaminated and shaved off the retinal surface by indenting from the outside the eye supporting, and even using it as a scissor to cut right through tissues here. What I'm doing is separating two retinal folds and using the cutter with controlling the duty cycle to use it as a vertical scissor to cut into this fibrous tissue to separate these two retinal folds instead of exchanging lots of instruments inside the eye. Point 2 is the vitreoretinal adhesions and the hyaloidal attachment. This is something where I'd like to highlight. PVD is a traumatic step in child surgery, and you have to keep it in mind. While separating the hyaloid, you have to look all around, not just where it is detaching, but even around the equators. You can easily create peripheral breaks while detaching the hyaloid is tightly adherent, so you have to be very careful while detaching the hyaloid in pediatric age group, looking at the periphery and at the same time at the central area. Tears can happen easily around the arcades or at the equator. Not just at the equator, but sometimes, like in this patient, he has very tight adhesion to the retinal surface. Notice what happened in the foveal area here while detaching the hyaloid. You drop an operculum right here because you aren't looking at the correct plane, and you can see the amount of traction that is exerted. So while doing PVD, it's very important to do it slowly in pediatric age group. And sometimes I resort to do it mechanically. The hyaloid is sometimes too adherent to the retinal surface to pop off by itself just by suction. So in this patient that had a bullous retinal detachment in a pediatric rhegmatogenous retinal detachment, bullous retinal detachment, I can't detach the hyaloid, and you can see that I injected the triamcinolone. How am I going to detach the hyaloid in something like this? And he has a peripheral break. What I'd like to do it mechanically, vacuum or aspiration, or sometimes using a Thanos scraper or a diamond dust scraper. It doesn't help in something like this. What I do is I inject first the perfluorocarbon to support the retina. I still know that I did not detach the hyaloid, and the hyaloid is still attached. Once this happens, I have a second hand to mechanically aspirate or mechanically grab the hyaloid at the optic nerve and start detaching it peripherally and looking to the adhesions till it starts to separate all through to the area that I want to have it detached from. Then once I pass the equator, you can do it with no perfluorocarbon, and you can see the particles of the triamcinolone attached, and this is the hyaloid coming off as one big sheet. Failure to detach the hyaloid means failure of the case at the end. So you take your time to clean up the hyaloid all around like this, and I keep the perfluorocarbon as a second hand. Then I know that now I have good retinal mobility inside the eye after you detach the hyaloid. So this step of surgery, you have to be careful while detaching the hyaloid inside the eye. Not just the hyaloid is tight, but even the ILM. When you attempt to do ILM in pediatric age group, they have healthy molar cells, which makes the ILM more contact or grasping with the retinal surface of the nerve fiber layer than doing it in an adult group. So you have to be very careful while detaching even or trying to remove the ILM in traumatic macular holes or cases like this. The ILM is not easily removed as in other. The same trick, you could use it if you put perfluorocarbon first. It helps you to remove the ILM or even remove epiretinal membranes. I always like in pediatric age group to have some support inside the eye, though they have more elastic retina than adults compared to that, but still you can easily create breaks, and in pediatric age group we try to avoid that, so you have to use what is comfortable in your hands to make that step safely done. Point number 3 is the lens issue. When do you remove the lens and how I'm contracting? The lens is very important for the visual development, especially in young age group. So you need the lens inside the eye as much as possible, or avoid removing the lens as much as possible in pediatric age group. Keeping the crystalline lens is difficult sometimes if you're targeting the vitreous base and you have a lot of adhesions or proliferation, you can't get to that easily, then you try to remove the lens. If you remove the lens, then the balance between how you correct the aphakia, if it was the other eye was phakic and he had no problem. So there is challenging in decision making when to remove the lens. Last point is PVR. Why I speak about PVR? There is a higher incidence than adults. There is a lot of growth factor inside the eye and longer life expectancy. You see a child with 9-year-old, 10-year-old with retinal detachment, he has longer life expectancy than an adult. So they will have some type of PVR a little bit down the road depending on the life expectancy. The longer complicated surgical procedure, if you have a child with a giant retinal break and there's a lot of laser or a lot of cryo, or there's a lot of breakdown of the blood-ocular barrier, then they have higher rates of developing PVR later on. Drugs, we don't have anything statistically significant yet that we can say, okay, I'm going to use this is going to prevent PVR. We tried lots of substances, including 5-fluorouracil, heparin, steroids. We still don't have something clinically significant that we can say that this is 100% sure that it will improve our results regarding PVR. Last question, do I use buckles in pediatric age group? Yes, I still use buckles in patients. Sometimes in ROP, sometimes in inferior retinal detachment in a phakic young adult with no PVD, I sometimes still use buckles. Retinal dialysis, I use buckles. Giant retinal breaks, even if I have a good surgery with vitrectomy, I'd like in some patients with PVR to put buckles around the eye, especially if they are young in age. This is an investment for later PVR happening later in life at the edges of the giant retinal break. You can have it, the first procedure looks nice, but 2 years, 3 years from the primary procedure, sometimes you get proliferation at the edges, and that's a case that I would like to put a buckle in the primary procedure. In circulating bands, sometimes I put it in conjunction with pars plana vitrectomy. Like a patient like this with the giant retinal break, you can fix it with vitrectomy. But I like to see it like this at the end, with a nice buckle supporting the edges here, even the lasered area lying over the supported area. If he develops any PVR at the edge, he is supported and you won't get recurrence early in life. And doing the least traumatic surgical procedure is very important, with the least amount of breakdown of blood-ocular barrier like laser and cryo. So if you can avoid putting too much laser, then that's definitely a good point. That's my first part of my presentation. Let's see real-life scenarios of cases. This is a case of rhegmatogenous retinal detachment. It was a stickler, and you can see the amount of proliferation. He's a very high myope, and he has a contracted hyaloid with membranes here. Summarizing what we said, we start by the PVD. When you grab the hyaloid, you can grab it from different directions, looking where the traction is happening. You don't want to be pulling here and you get iatrogenic retinal breaks. So it has to be careful from one side, then you might grasp it from a couple of points to try to avoid creating breaks. Then you look at the other end here till it pops off, then you start using your cutter. Identifying the membranes. Once you open the retinal surface, you know that there is stiffness. Then I like to inject the dye before the perfluorocarbon because it stains the membranes, everything you can see underneath. Whether you use dual blue, you put it before you put the perfluorocarbon, then you can see a stained retinal surface. Once you start stretching the retina with the perfluorocarbon, flattening it, then you can see the areas that you have to deal with, whether removing the membranes or whether you're doing it both, removing the ILM and the membranes by itself. Once this happens, I'd like to clean the retinal periphery totally, then put my laser burns and put the silicone inside the eye. This is how it looks like pre-op and intra-op at the end of surgery. When you have a nice open surface with a clean retinal surface, is very important to avoid recurrence in pediatric age group. This is a case of Wagner. It has even more vitreous adhesions. And if you miss the vitreous, then you miss the case. Look at the hyaloid. It's very difficult to separate again. It doesn't come off just by vacuum. You can see that you are doing the vacuum, but the retina is tightly taut by the hyaloid attached to the retinal surface with the membranes. So you can see that sometimes I like to do it mechanically. Even mechanically, it doesn't come off all as one piece. Sometimes it threads, and you have to identify where is the remaining vitreous. You may do it once or twice to grasp the hyaloid to make it pop off the retinal surface, as you can see. And as I said, I like to do it under perfluorocarbon because it supports the retina. While it's detaching here, the retina is pushed downwards, which gives you another shearing force to help you with the total amount of traction on the retinal surface, makes this step a little bit easier or less traumatic before you do your laser and membrane peeling and start putting the laser inside the eye. And you can see at the end that that patient had Wagner syndrome and he has very high myopia. The retina is very thin, and any traction could easily create more retinal breaks. Joint retinal tears is another variant. It's different. Yes, it's different. Why is that? Because here the incidence of PVR in longer life expectancy is high. Point one. Point two, if you remove a lot of retinal tissue while trying to attempt to open the retinal funnel and remove epiretinal membranes and do extensive retinectomies, then you face the problem of hypotony because the choroidal surface area is a problem. So you try to save as much retina as possible while cleaning the retinal surface to not even utilize the peripheral retina, which sometimes you say that it's not seeing anyway, I'm going to remove it, but sometimes it's covered the choroid and it prevents the hypotony that happens. So you have to spend time opening up and clearing the retina as much as possible. You do release it from the retinal periphery, but you try to keep as much as retina as possible. Sometimes the retina looks worse than what you can achieve. If you give some time bimanually, like here I use the scraper or the cleaning the retinal surface while supporting the retina, you can easily have more retinal surface or sparing retina inside the eye, opening it like this before putting your perfluorocarbon to support it, then clean the retinal edges. I don't just cut these edges of the break, but I spend time cleaning them or rolling them hand by hand, removing as much as possible of the membranes. Sometimes at the end you can put a buckle at the end. But covering the choroidal surface area is very important to decrease the post-operative hypotony. I like to have tissues inside the eye. So I sometimes do rolling technique, hand by hand, opening it by 2 diamond dust scrapers. The retina is sometimes open and it's good, so you can put your lasers more peripheral, then you have to put it more posterior if you remove too much retina while dealing with this case. So spend time opening up the retina and cleaning the retinal surface bit by bit and putting the buckle at the end, sometimes helpful if you have residual traction. Then you put your laser at the extreme retinal periphery to have some clear posterior pole at the end in cases of giant retinal breaks, which is a high risk of a PVR later on. So you have to spend time dealing with these patients. Another variant is PHPV. I'd like to show you this case of PHPV. What I do is that when I insert my trocar cannula, though I'm doing a 27 gauge, I like to put the infusion in the lens first because you don't know what's behind. Though you can do ultrasound, but you still don't know if this stalk contains retina or it doesn't contain retina attached to the posterior part of the lens. So what I do is I place the infusion cannula, the trocar here, 2 millimeters, but I'm pushing it in the lens because you need infusion if you're going to use the cutter. So this is what I do. I can see it inside the lens, then I put the cutter, remove the lens. We have 2 membranes to deal with. One is the posterior, and that's where might be the retina attached to it by the fibrovascular tissue in the PHPV, and the anterior one. The anterior one is responsible for the contraction that happens in the ciliary processes right here. So this is what I'm going to show you. Once the infusion starts, you can see that I'm removing the lens here. I'd like to start cutting this posterior membrane very carefully, leaving the central part, because you know that the stalk comes in the central part. So you leave that till the end. You release the anteroposterior traction first. Once it releases, then I know that there is something clear here. There is not too much tissue behind in this case in particular. Then I release the circumferential traction. You can see once you cut it, the ciliary processes snap back in place again. The ciliary processes are dragged centrally. So once these starts to open up, then I can start opening up this membrane, identifying where is the stalk coming from the nerve, and release the residual circumferential traction that exerts ciliary body processes. And you can see this is the stalk. It wasn't bad, and he had a very nice posterior pole. You can trim it all the way anterior to posterior to like this. But you open it first carefully, then at the end it's a 27 gauge, and you have a nice case like this. Lastly, I want to show you retinopathy prematurity, which is a talk by itself, but I just wanted to show you that we don't give up hope in retinopathy prematurity, and sometimes that these cases can do well if you operate them correctly and in a time fashion. So this is a stage of a 5 ROP. In these patients, I remove the lens. So I'd like to put the infusion first inside here. I sometimes remove the iris, or a lot of times I remove the iris to have better visualization like this. It's very important to cauterize these blood vessels in the early, so you have a nice open area. The problem with the iris is sometimes you have renal proliferation, or the retina, residual retina sometimes sticks to it. So that's why I'd like to remove the iris in the beginning of the case to give me good clearing, and at the same time know or decrease the incidence of renal proliferation because of the iris. Once I remove the lens, I start opening the anterior hyaloid. Then I deal with the transvitreal vectors. There are several vectors inside the eye. One coming from the optic nerve to the retinal periphery or the retinal trough, and this is the pillar. If you have to cut it, you have to cut it first at the trough, then dissect it all the way to the back of the eye to have relaxation of the retina. There are two components in this eye. It's a tractional component, as we all know, and sometimes there is extensive subretinal fluid. So I'd like to deal with those. First, release as much of the traction on the retinal surface, dissect the transvitreal vectors, and once I have a loose retina or a redundant retina, then I start to aspirate the subretinal blood and inject something to stabilize the retina like Heron, which I will show you during this case. So I'm doing the dissection here, cutting it. I sometimes use bimanual surgery, or a lot of cases I use bimanual surgery. The best cutting blades I need, so it might be a 25, or sometimes I exchange 23. Then I cut snips all around circumferentially to release the circumferential traction. You can see the ciliary bodies tracked here. This is the stalk coming right here, so I cut it from the retinal surface after dissecting it from the trough. Once you do that, then the retina starts to open posteriorly. It's very important, and you can see why is this retina looks like it's exudative retinopathy, not just attraction, because there is a lot of subretinal blood. So once you start removing as much as possible from the retinal surface all these sheets and identify the retina, then you will deal with the subretinal blood later on. It takes quite some time to clean the retinal surface. Bimanually, you have to understand the anatomy and why the retina is twisted like this. So bit by bit, you remove the correct planes and the correct vectors. Once you do this, the retina will start to open. When you see these patients, sometimes in the clinic, you say that, well, they're maybe not operative, or what's the child's benefit? This is a change of stage 5, which I was doing the dissection, and here after I remove much of the fibrovascular proliferation, I'm aspirating the subretinal blood by a needle. You can see it right behind the trocars. This is active aspiration. This helps the retina to start opening and settling up, and it decreases the time for the subretinal fluid to resorb. So once you do that, it's actually blood. This is subretinal blood most of the time. And when you aspirate it, it starts opening up here. I will show you what's in the needle. I already aspirated it. Then I'm pulling it out of the eye. There, this is the needle right here. And this is the blood that comes out. Extensive dark blood with subretinal exudate. So it makes sense to remove it. Once I do that, then I just start injecting Heron. Heron stretches the retina and pushes the retina to the back part of the eye like this. Then you have a nice open retina. You wait for time. What would this look like in the early post-operative period. It's very important. This is how it looked like before and right at the end of the surgery. So seeing a patient like this, we don't tell him no hope for surgery. But depending on the age of the presentation, the amount of the subretinal fluid, how much the retina is closed on the ultrasound helps us in decision making to have an eye like this at the end. If you look at the operated eye and the unoperated eye, here there's no fixation at all. You can see the light, while the operated eye, 4 months after surgery, you can see that he has an open posterior pole. This is the residual peripheral traction, but it has nothing to do with the central pole. Your aim in stage 5 is posterior pole attachment, and this child is fixing with that eye. He has some type of vision. What does the retina look like? If you wait for 6 months, it flattens up like this. Of course, there is a lot of RPE mottling from the lots of subretinal fluid that was there, some epiretinal proliferation, but the child has posterior pole attachment, which sometimes gives him good navigation vision. Like in this child, he's already now more than 2 years of age. At this child here, fitted with glasses. After doing surgery, he starts learning skills. If you have good visual aid teachers, they start learning skills like walking by themselves, identifying objects when they come close. Effective correction was done right after surgery for a stage 5 IOP. You can see that he starts to grab objects at a very close distance. So these are very important to give them the second part, which is the post-operative rehabilitation. It's not just surgery. Surgery, preventing reproliferation, preventing hemorrhage, and at the same time doing well post-operative rehabilitation with a good vision aid teacher helps these children to gain vision instead of losing all if they were unoperated. So in summary, PVR in pediatric age group shares a variety of forms of retinal detachment, as we've shown lots of variants. It is more challenging to deal with according to the complexity of the detachment, the nature of the disease, and the age when we saw the patient. Higher healing response, which is responsible by the growth factor mediated and longer life expectancy, adds to our challenge and the stability dealing with these patients. We have to keep that in mind in the original surgery, deciding what to do. The least traumatic surgical procedure to get the job done is very important to decrease the later post-operative PVR that we see with pediatric age group. So this was my talk, and let's open up a discussion then.
Thank you. I mean, you put a lot of meat here in the panel. There is a lot of stuff to talk about. So, I mean, you show very nice videos, very nice presentation, and I have some questions for you. And then there is a Q&A section. So all the participants on the meetings, they can ask a question if you want, or if you want to talk, you can raise your hand and we will allow you to talk. So I saw the first question. Yeah, I saw that when you do create the sclerotomies, you spoke about the importance of the sclerotomy, making the sclerotomy the right measurements based on the age of the child. That's really important. And I saw sometimes when you do this, the sclerotomies are really tough to make. I'm talking this because a lot of fellows are listening to this lecture. Sometimes what I do, I do a pre-cut with the MVR bead because that helps, you know, and I noticed that even
Dr. Marco, I think that your sound is off.
Well, until Marco replies back, I think the point of using the blade first is also a point to do. The thing is, entering the eye, the first cut is very important. So sometimes when you use the blade or the MVR to fashion up the entry is a way before you put the trocar cannula. So I do agree totally with Marco that in some of the patients, I'd like to do the initial cut by the MVR, whether it's a 25 or less, then put the trocar cannula. It's a matter of how you guide the trocar inside the eye. You have to know the tissues inside, how close they are to the lens, then you push it inside. The easiest, of course, if you use just the MVR, make the initial cut, then put the trocar cannula. But I agree with Marco that sometimes, of course, I do use a blade.
I'm back, I think. Can you hear me now?
Yeah, I can hear.
Okay, perfect. Sorry, I just was gone for a second. Another question is that you mentioned when you are cutting tissue, you use the cutter as scissors, and that, of course, it's a very good thing to do, and it's much easier when the caliber of the instrument is small. I mean, sometimes I use 23 gauge in these small eyes, and I think, oh my God, it's huge. I mean, I rather use a smaller gauge if I can. Can you tell us which parameters you use to achieve this scissor function? If you change the parameters in your, do you use a Constellation or you use another machine?
I use both machines, as a matter of fact, but I agree with you that if I'm using a blade, if I'm using a cutter to delaminate, I will do that with a 27 gauge, not with a 23 gauge. I use high-speed cutting with the least vacuum when I come to tissues. Sometimes when the tissues are tough, I decrease my cut rate. I sometimes decrease my cut rate even to 1,000 or less. That helps you to do one cut at a time, so acting as a scissor. But if you are planning doing shaving or delamination with that, I would rather go for a smaller gauge, not for a larger gauge. But again, what is safer in your hands is the way to go. Sometimes I don't feel that the cutter did this right job, then I have to still use bimanual surgery and use scissors. If I use scissors inside the eye, I'd like to have the straight scissor. It gives me the functionality by having a good cutting blade while using a 25 gauge. If you use a 20 curved, sometimes you don't have a good cutting blade at the end to put it inside. But the straight scissor, usually, to me, I do a lot of things with it in the pediatric age group.
Another question is that everybody, we know that when you do pediatrics, posterior vitreous detachment is very tough. You know, I had even some cases operated, even by myself and other colleagues, when I'm sure they use PVD and they use Canacort, that sometimes they come back with a redetachment, you stain again, and still vitreous is there. So my question is, do you always stain once or more than once in these cases? And how do you avoid to basically leave vitreous, which sometimes is lamellar, and maybe we don't notice with only one staining? Did it ever happen to you?
Well, the thing is, depending on the age, sometimes you can't get 100% PVD. Like if you're doing, for example, a very early fever or a very early ROP, you're sure that the hyaloid is there.
No. I'm not talking about ROP. Yeah.
But speaking about retinal detachment, to speak about retinal detachment, triamcinolone is one of the things that identify the tissues. It shows me what's inside the eye. If it doesn't pop off by itself while doing it just by vacuum, then I sometimes like to use the Tano scraper or the finesse loop to grab an edge. Once you create an edge, the fluid by itself starts to dissect the hyaloid. But in certain cases, when this fails to happen and you still see that you have the triamcinolone particles, you're 100% sure that there is still hyaloid on the retina. So it doesn't mean that if you saw a wave coming up that this is the PVD, and it's then when I start to put perfluorocarbon and do mechanically try to grasp it as a membrane and bring it off. One of the things that we saw that if you are attempting removing the ILM, when you sometimes do an ILM peeling, you find that the hyaloid is already on the ILM and it comes up in the periphery once you started to peel the central area, because it creates a tear in the hyaloid in the central area, which the wave of the fluid helps to dissect the rest of it. So mechanically, I think in most of the pediatric cases, I might do mechanical separation of the PVD. Triamcinolone is definitely a good help, and seeing particles at the end of the surgery is still a warning sign that you missed some hyaloid inside the eye.
Okay, so you don't, because sometimes it happens that you really are kind of sure after staining once with the Canacort, and then basically patient comes back, maybe you put silicone oil, you remove the silicone, and there is still some vitreous left. Do you think then ILM peeling would be a technique to be doing to make sure that there is really no vitreous whatsoever anymore? Or you think it can be dangerous in this patient population?
Well, I don't recommend it in primary retinal detachment for pediatric age group. I mean, it's better spending time trying to remove the hyaloid than it is spending time removing the ILM and facing any problems that could happen with removing the ILM. The ILM will all be in the central area, but if there is hyaloid around the arcades or in the nasal quadrant, it will cause proliferation. So identifying the radial hyaloid and detaching it in the initial surgery, to me, is more important than removing the ILM in the initial surgery.
What about if the patient presents a stickler, for example, with a fresh stickler with PVR already? Would you consider doing ILM at the first instance, or would you do still the same? No ILM peeling?
In most of the cases,
PVR.
Yeah, PVR is an indication for me to remove the ILM.
Okay, great. And we saw the technique you use perfluorine and use blue for it, right? Is that what you use all the time?
Yes, I inject the blue after. Sometimes if you needed to inject the perfluorocarbon first, you can still inject the dye through the perfluorocarbon. So initially I stain the retinal surface, then push the perfluorocarbon so it flattens up a stained retina. I like to see at the end the stained retina to see where the traction I'm going to deal with. But if the initial procedure you injected perfluorocarbon first and you didn't inject and you find that there is some quadrants that you are suspecting, you can inject the dye through the perfluorocarbon and still stains underneath the PFO.
And a question about the buckles. So is it, do you show the cases where you put buckles? I mean, we did a little study in K-Cash and we saw basically not much, actually we saw no statistically significant difference putting the buckle, not putting the buckle. I usually put in when I'm not sure about my PVD detachment, if I'm not sure that the PVD is detached fully, or if there is a lot of pathology. Can you summarize again, when do you use it, the buckle, in which cases? Just for the fellows.
Or you mean as a whole?
Sorry, no, in this type of detachments.
Yeah, well,
excluding ROP.
Yeah. Well, I use it mainly in the cases which I'm missing any traction inside the eye in the initial surgery, or if I didn't do a good job in the peripheral retina. Like if I'm decided leaving this patient phakic and I need the patient phakic, I don't want him to remove the lens and he has a normal other eye, then I try to keep the patient phakic, then I put a buckle. The thing is, if you do comparative study, how long it is. If you see these patients maybe in a 1 year term, well, it doesn't make a difference. But if you see these children like in 4 years, 5 years after, then they start developing proliferation at the edges of the tears or in the peripheral retina, which you didn't deal with. So buckles, if I need any proliferation, I would prefer to put a buckle. I don't need an inferior retinal recurrence in a child that is phakic, then I have to remove the lens and do the job again. So there is no harm putting the buckles. It's an investment for the future rather than sharing a success rate in the initial procedure in the first time.
No, my idea was that this was due to the fact that probably vitreous was not removed fully in the periphery. In that case, I also put the buckle. And it's true what you said. I saw kids operated when I was in Holland by Zivonovich like 20 years ago, and still they would present 20 years later with some PVR at the edges. And it is a tough problem. So we really need to follow these kids for very long. It's just not a surgery, as you said, but it's the whole process around it. And also the rehabilitation. Regarding rehabilitation, do you have somebody to follow the patient for you? How do you do that? And if you remove the lens, when do you usually implant it?
Well, I don't
Or do you implant it?
No, I personally don't implant it. I'd like to see them corrected with contact lenses or with glasses for quite some time, because the incidence of having PVR and other problems, if you are very quick in repairing it by putting a lens inside the eye, especially they have a variation in the size of the eye, and that means a variation of the IOL. So I'm reluctant in putting IOLs in pediatric age group. I like to see the retina flat first. Things are okay. You can easily correct the aphakia by contact lenses, even if they're done with the Department of Pediatrics. They take care of that. Glasses. Then at the same time, when there is no incidence of PVR happening or the eye is very quiet, then they get a good calculation. Then they can put the IOL inside the eye. Regard that part. The other part is visual rehabilitation. It's not just on our as physicians, but there's low vision teachers that help these children to have a plan for stimulating their eye and trying to prevent amblyopia.
Okay.
Hello? Can you hear me still, or am I gone?
Yes, we can still hear you.
Okay. Do you have questions, Adel?
Yes. So there's a couple of questions from our attendees here, and I think Dr. Maysa Swalem also is interested to ask a question. I will allow her to ask. If you're free to ask, Dr. Maysa. You're unmuted now. Not sure if she is.
Is she unmuted?
Here, she can hear us. Okay, a couple of questions from the attendees here. You showed very nicely the surgery in PHPV patients, and you mentioned that you like to do your you put your infusion line inside the lens to make sure that things are okay, because this is the only place you're sure that there is no retina actually. So these are very challenging cases, and I think dealing with them can be tricky in some situations. There are tendencies for these cases to be divided sometimes between pediatrics and sometimes between VR. Do you see any clear guidelines into where should these cases be directed according to the presentation?
Well, in most of these patients, when you do an ultrasound, there's smoke coming out of the optic nerve. These patients are more eager to be done in the retina department. I leave the aphakia correction to be done in pediatric department, but I have to give them at least a clean eye with no retinal problems or no risk of the retinal damage. Because sometimes when you started it as an anterior segment problem, you can easily, sometimes this top that is coming out has some retina dragged into it, and you don't know how far this retina is dragged. It might be all the way to the back part of the retina, the back part of the lens. Then you have damage there. And it's easier for us to use the cutters and try to open up the posterior capsule and make a clean part of that, doing it in the retina surgeon. But of course, there are some patients that I refer to pediatric anterior segment to deal with these patients.
A question here from one of our fellows. He's asking about scale buckle. Do you think it increases the risk of slippage? And if so,
Slippage?
Yes.
Slippage.
Retinal slippage.
Yes.
Sorry?
Retina slippage, I presume, right?
Yes.
Decreases the rate of retinal slippage.
Increases the rate of retinal slippage.
Now, if you do it, I don't tighten the buckle except at the end of the case. The buckle, when I put the buckle, I put it and leave it loose until I see the same picture as a vitrectomy. I'd like to see at the end that everything is there as a vitrectomy. The buckle is something that I put at the end just to support the retinal periphery for later PVR, as I said. But I don't tighten the buckle while I'm still doing maneuvers inside the eye, like going from perfluoro to silicone or perfluoro to air. I always do that with completely loose buckle at that part. Once the retina is flat and I lasered, everything looks okay, then I start tightening the buckle around the eye. So it has nothing to do with the slippage there.
We have a question from Dr. Suleiman. He's our pediatrics retina here at KKish. And I'm Suleiman, the mic is yours.
Can you hear me?
Yes, Dr. Suleiman.
Dr. Ehab, thank you for the great lecture as usual.
Thank you.
I have a question regarding patients with who present to you vascularly active ROP with detachment and an eye that requires membrane peel rather than transvitreal surgery. So like a stage 5 open funnel vascularly active disease. Do you wait until it becomes vascularly inactive because of the risk of bleeding that makes the surgery more difficult and you may lose the eye, or do you use anti-VEGF pre-operatively, or you just go ahead with surgery?
That's a very nice question. Well, in ROP, once you have an open posterior pole, you know that it will be closed. It's an active eye. If it's an active disease, then you can easily go within a couple of days from a 4B to a 5. So I don't wait on these patients. Controlling the blood, there are several ways to controlling the blood, whether intraoperative or preoperative. So the question about waiting, no, I don't wait. The fear of the bleeding, I usually inject these patients that have engorged blood vessels or weren't treated by laser before and they just came first presentation as 4B or even going into 5. I inject even the day before. So if I see the patient in the clinic and he needs the injection, we do that day. Then the second day or the day after maximum, within 48 hours, I go with surgery. I'd like to keep that phase very close because it triggers the TGF balance. Once you decrease the VEGF inside the eye, then you get a TGF shoot. The TGF shoot is responsible for the fibrous tissue that happens inside the eye. So I'd like to keep them very close. Intraoperatively, there's other precautions. Usually when you trap the kid and you know that you gave him an anti-VEGF injection, if the retina looks pretty good to deal with, then I start like that. If there is still vessels that are high risk, of course, I use diathermy sometimes inside the eye. I sometimes use helon while I'm doing dissection. It keeps the blood away from the dissected area, so you can deal with these types of engorged vessels easily inside the eye. If you increase the intraoperative pressure, you have the problem with corneal edema that could happen a little bit down the road while doing lengthy procedures. So there are things that you have to keep in mind. The first line is anti-VEGFs, keeping in mind that I have to operate maximally within 48 hours. If not, then I start dealing it with intraoperative measures to control the hemorrhage.
Do you give anti-VEGF? Sorry, do you give anti-VEGF intravitreally and with the presence of detachment, or intracamerally? How do you give it?
No, I give it intravitreally, but it's very important that you have a clear lens so you can see where you're going. You don't go too deep. The problem is, even if you inject it intracamerally, it will diffuse to the back part of the eye. There is no problem with that. But how far you go in with the needle is very important. So I'd like to do that even underneath the microscope so I see where my needle is going in and dissect. It doesn't go directly there, but you have to guide it in the correct plane, then give the injection. If you can't see behind, if there is a lot of posterior synechiae and there is persistent tunica vasculosa, then in that case, I will inject it in the AC.
Thank you.
A question from Prof. Maran Abu Amma. He thanks you first for a very nice presentation and asks you about the preferred timing for silicone oil removal in pediatrics and how to deal with imminent hypotony if there was a large retinectomy.
Excellent question. Well, the problem with silicone, of course, we know that the aim of injecting silicone is having retinal attachment or until the chorioretinal adhesion takes over. So usually keeping it in a pediatric age group is not a good function because you can't keep a child face down. You can't keep a child in the correct position. So the role of the silicone is not that as in adults. So removing it once it did its job by creating a good chorioretinal adhesion, usually I start removing silicone maybe 2 months to 3 months post-op. Because I know that this child is not gaining anything from the silicone inside the eye. They never keep their face down. They're relying on their backs when they sleep. So there's no good functionality from the silicone. Once it did the job, then I start removing it. Sometimes I use longer acting C3F8. To me, in most of the surgeries, is a good thing than silicone. What was the second part of the question? The hypotony. Hypotony is definitely a big challenging problem to us, and that's why we sometimes keep silicone inside the eye, not for the sake of the attachment of the retina, but for the sake of the fear of the hypotony. One of the things, as I said, how to counteract that, preventing as much PVR or cleaning the retinal surface as much as possible. Dealing with the retinal periphery is very important, not to have any residual ciliary body shutdown or ciliary body traction that causes hypotony. Leaving as much as retina covering the choroid intraoperatively is very important. To cover the choroid. Sometimes this retina might not be functioning, but it covers the choroid. So I'd like to keep that in place once there is no PVR or rolling up at the edges. I'd like to keep that. One of the things that we've tried and we've been doing over the last couple of years, if you have like a 14-year-old child and we have a problem of hypotony with a nice flat open posterior pole, sometimes we put a tension ring in the anterior segment, it plugs the angle, so it decreases the outflow of the fluid. So it's one of the things that we've been using for quite some time and we're putting up a paper about it. We have pretty good results with that.
One thing that's been advocated by those who are doing endoscopic surgery is that you can get better exposure to any membranes that are growing anterior and you have lower risk of hypotony. Is this something that you advocate in terms of when you think of preventing PVR?
I personally have no experience with endoscopy, but I think with our current visualization techniques, when you have good indentation, you can see everything inside the eye. Like I showed that you could see the ciliary bodies, ciliary processes while doing it. So with good visualization, the better microscopes, the viewing and everything, there is tricks that you can see the extreme retinal periphery and get the job done. The thing is, if you have to do that, then you have to sacrifice the lens. But once you remove the lens, you can see everything, including the ciliary body in most of the patients that you're dealing with.
Adel, if I may comment on the hypotony, because I think you have made a very good point. You really need to take care of the ciliary body because, I mean, in my experience, the reason of hypotony is because there is a proliferation of ciliary body. I don't believe personally that exposed retina really gives a big difference. I've been doing a lot of retinectomies for many years, very large ones also, and never had this unless there was really problems in the ciliary body proliferation. But really a very good clean, and you can do this without endoscopy. You can really do it, as Ehab said, with a good scleral depression, you can see everything. Yeah. Good, go ahead.
There are a lot of comments about the nice videos you showed and elegant surgery. But people were asking about the type of microforceps you like to use. You said you like to use the straight scissors, which is interesting to me. I think we here at Kekish are big avid curved horizontal scissors.
Well, I must say that curved scissors are very good for me in adult groups. If I'm doing adult group, I like the curved scissors. But if you go to smaller scissors, which you need shorter blades, then you have non-functional blades. If you have a short blade and a curve at the same time, then you lose the cutting surface or the working area of the scissor. So that's why I like to have it straight. So it gives you a good cutting distance. So you can engross the membranes and have a good cut. If you try, for example, the 27 gauge curve or a 25 gauge curve in a pediatric age group, it takes space inside the eye. And at the same time, the tip or the cutting area is very small. So it's difficult to cut tight membranes. But you have it in a straight form, you can do much with it. You can use it vertical, you can use it straight, you can use it in more than one fashion.
No, I agree with you. The reason why they are biased on 23 curve is because it's because of me. I really like them, but indeed, as you said, I use them always 23 gauge, because if the gauge is too small, they really are not functional. Actually, they work adversely on what you are doing. But 23 gauge curved, especially the one from Dork, are great. And you can use them in a mixed gauge. You know, I use them in a mixed gauge. I use 27 cutter and maybe those scissors. But I don't use Trocar. When I do ROP, I don't like to use Trocars, because otherwise I'm not able to use the shaft is too long. Anyways, go ahead, Ada.
Question from Dr. Mohammed Hazzazi, and he also praises your nice talk. So when do you give up on operating pediatrics patient after multiple failed PVVs?
Well, that question goes to Marco also. Well, it's a tough question. The problem is I try to do as much as possible with pediatric eyes. The problem is they have a long life expectancy, and you have to give them the right to take their chances. You can't tell them, well, we did 2 surgeries, so the third is not going to be functional. But if they have a really damaged retina or optic atrophy or something like this, then this is a sign which I like to even share with the patients and tell them, with the parents, I tell them, well, if this child, I would consider that further surgery might do him harm, regarding phthisis or whatever, and there is no visual benefit. But if he was single-eyed, I would take all my chances with him trying to achieve any type of vision. Let's remember again that we did surgeries that cost 200,000, 150,000 to put a vision chip inside the eye, and they're gaining like maybe navigation vision if they give it. So if you have a child that has partial posterior pole attachment and he can have navigation vision, at least when he starts his life, that is important than giving up such things. But if you have optic atrophy, for example, if you have the other eye, which is a good functioning sound eye, then I won't give him the trouble going into 1 or more or 2 surgeries, then at the end having a phthisis or having corneal band shape retinopathy from further surgery. Mark, I'd like to listen to your comment also. When do you give up? At least
no, I mean, I agree with you, you know, but I'm like a pit bull, you know, I never give up. Adel, unless I see really there is no really light perception anymore, or as you said, there is optic atrophy, you know, there is really nothing to be done. But if I can still save some even light perception, in these small kids is very important, you know. They can perceive when it's light, when it's dark. They can maybe navigate. It's extremely important, I think, to try everything you can. But of course, when there is no possibility anymore, and I'm sure there is no really perception of light, or there is atrophy of the disc, yeah, then I will stop for sure.
Prof, Ehab, you showed very nicely the procedure done in both 25 and 27 with Dork machine, and did you find the shortness of the instrument of huge advantage going into, I mean, with the cutter itself?
I think when we will have both packs available from Dork and Alcon, that would be a good add-on for doing pediatric surgery, especially when you have small size eye. If you're dealing with a 14mm size eye, 16mm, or even 18mm, I would prefer to have a short distance inside the eye to bring my hands closer to the eye. So you have good manipulations or fine manipulation. But working with the regular 30mm probe, it's usually too large, and you have your hands too far from the size of the eye, especially if it was a very small eye. So when you have a shorter probe, you could easily come inside the eye, and you have a good functional fulcrum inside the eye. So I prefer in these patients the shorter sets. And I think Dork are releasing the shorter sets soon, which will have also a shorter infusion cannula, cutter, light, and vitrectomy probe.
I think one question that always boggles me, maybe Dr. Mora also knows about this, is have you find that a lot of instruments tend to be very long in the part that's not related to the eye? I mean, now they're dealing with what's going inside the eye, 30 millimeters, but when you're using a biome, you tend to have a lot of issues hitting the biome with most of the instruments that we have in the market.
That is true, especially in small size eye, because the microscopes comes even closer. When you have a small size eye, small size head, you have to bring the microscope closer, and this narrows the distance or the space that you have inside. So one of the things example, with the vitrector, I like to always remove the cover. There is too much things that connect to the probe. I just like to use the smaller part. So now imagine that even this smaller part will be even smaller with a smaller trocar. Once you have this new instrument, it's going to be better. But having this short, close distance between a microscope and the child's eye definitely makes it too crowded inside the eye. I have too much traffic there.
Yeah, I think Ehab asked you that question. Ehab asked you that question because you always hear me swearing about that, you know.
Then you should record that.
But you know, there was a catalyst at some point who was making instruments based on your needs. Do they still do it? Yeah, but I don't know actually.
Synergetics is the company that makes a customized pediatric set. So you can tell them that I need this length with the forceps, with a special size forceps and a special scissor, and they make the pack and it comes for you for that case. But of course, it's a hassle. If you're doing cases regularly, you need to have that in your OR. But Synergetics is the company that does that.
Synergetics or Catalyst?
I'm not sure about Catalyst. Synergetics is the one that used to be pre-customized packs. Okay.
Sulaiman wants to ask a question as well.
Yeah, I have a question regarding decision making. If you have like asymmetrical fever or ROP with one eye is stage 5, the other eye is a dry fold, that you cannot tell how much functional vision is going to be out of that eye, the one with the dry fold. So do you operate on the eye with stage 5, or you just say, well, he has another eye that probably is going to have some functional vision, I'm not going to touch?
Well, the problem is in these patients, usually I look at the fold at the other eye. If you're dealing with a stage 5, you know ahead of time that your best results will be navigation vision. And a child with a fold will definitely have extra foveal fixation, but macular fixation, depending on the size of the fold. So if the fold was also taking the blood vessels, then most likely has extra macular fixation, which is still a resolution of 360 or better. So that eye definitely is going to be a competition for the ROP eye, whatever results you're going to get out of that. The child will be fixating with that eye, and he already developed cortical visual development of an extra foveal fixation once he has a dry fold. And they function well, a resolution minimum of 360, depending on how much retina is entangled in that fold, but they have good fixation. If he has another eye with the stage 5, then definitely there is less likely that he will gain any benefit from the stage 5 once he has a dry fold in the other eye.
Okay.
I deal with dry folds, by the way, but depending on the age of the presentation. If there was early closing of these folds and he has both eyes, I'd like to operate on these folds, trying to achieve foveal fixation, try to flatten up the central area. So that what happens is these macular folds starts to close, then they are dragged. So depending how much retina is grabbed in that fold, then that's the visual acuity. If it starts fixating by a more peripheral area, then the vision knocks down to even 560 or starting getting less and less and less. So I sometimes very early I like to flatten up these or remove the vectors to have a flat macula as much as possible early in life.
What about extramacular folds?
Extramacular folds, you don't have to deal with them, but most likely they always develop macular. But extramacular folds, as an ROP, for example, or fever, you don't have to deal with them because the child has an elastic retina. He has more retina than the choroid. It's chronic traction. It doesn't happen all of a sudden. It happens like chronic traction on elastic retina, ending up by having a flat retina all around and only the fold. If it's extramacular, then you don't have to deal with it.
Excellent. I have a question. Is there a role for VEP in those cases before you operate? Do you do this as routinely in those cases of ROPs or bad RDs?
Well, recordable VEP with a no light perception measurement is still an indication of surgery, because you might get a no response to light in a child with ROP, but he has a recordable VEP. That means that he has functional retina, or there is electricity in the retina. Then it's worse to operate because the child might not know what light is, might not respond to the light. So the decision making is a recordable VEP. If he has a recordable VEP, then it's worth operating. Then you add to that the age of the presentation of a child. If it is recordable and the first presentation is at 8 months of age, you know that he has some damage to the photoreceptors because of the presence of subretinal fluid for quite some time. The configuration of the attachment, if it's a stage 5 and closed for 5 millimeters between the optic nerve and the beginning of the retinal funnel, then this part will never be opened intraoperatively. So there are a lot of things to put in mind when to operate. But if you're asking about the question comparing BEP to light response, BEP is an indication to operate if it is recordable.
Yeah, I think we are reached the end of the webinar. We really thank you very much for this very informative, very didactical, and very beautiful presentation. We really look forward to see you in real life instead of with this world behind you. Thank you.
Also.
You put some coffee.
Cheers.
No, thanks a lot, and I think everybody learned a lot from you today, and I will see you soon, hopefully.
Thank you so much for your invitation. I enjoyed the chatting with you all, and I enjoyed the session. And thank you again, Kash, for the opportunity.
Thank you. Okay,
Ciao.
bye-bye.
See you. Bye-bye. Bye-bye. Bye-bye.